And Dr. Rui is online. He'll be talking on early diagnosis of midbrain, hindbrain anomalies.
Hello everyone. Just
Over to
please
you,
let
sir.
me know please if you hear and see me.
Yes, sir, you are very well visible and audible.
Okay. So hello everyone. I'm very excited to join you again. This is going to be a fantastic session. We have really the most important, I think, people in the world regarding midbrain, hindbrain. So it's a huge honor and pleasure for me to join a session with Professor Dobbins and with Gustavo and Nina, which are my close friends and mentors. I will focus in this discussion about the midbrain, hindbrain but from the early perspective. So the early ultrasound, and I would like to show you how to perform an early neurosonography dedicated to midbrain, hindbrain malformations. Now, you all have seen yesterday many of these images at 12 weeks, the brainstem and the midbrain, hindbrain, the anatomy of the posterior fossa. And you all know from your daily practice these images at 20 weeks of the cerebellum, both on the coronal, the sagittal, and the axial, which is the screening view. However, there is a big question, I think that like a big elephant in the room, what's going on in between? What's going on between 20 and 12 weeks? Because, you know, this brain did not achieve its mature appearance 2 days before 20 weeks. Something happened much earlier. And what I'm claiming is that during this period, it is, I call it the birth of the mature midbrain and hindbrain. Now, I would like to highlight a few technical issues for the ultrasound because it requires high level, high quality ultrasound. So let me give you just some tips and tricks. First of all, remember that our acoustic windows for a good neurosonography includes both the anterior and the posterior fontanelle. However, when we are talking about the midbrain, hindbrain anatomy or the anatomy which is located inside the posterior fossa, we always must use the posterior fontanelle and sometimes the mastoid fontanelle, but the posterior ones. We cannot see very nicely the posterior fossa going through the anterior fontanelle. Bear this in mind. And I just remind you that at the early second trimester, first of all, the bones are still thin and minimally ossified. And in addition to that, you have very big fontanelle, so it's a fantastic acoustic window. You just need to manipulate the fetus and use it. Of course, by the transvaginal ultrasound, this comes even without saying. Another important technical part, which I really like to emphasize, because for some reason this is a point that has been forgotten, in between the lines, is you need to remember basic rule of physics of ultrasound. You have reflection of the sound is what eventually creates the pixels. And ultrasound waves reflect backwards to the transducer whenever you have a change in the density of the tissue. And as this illustration shows you, the energy propagates inside density number one, then there's a gap or a change, a line of change on density, and along this line you have reflection, and some of the beam will continue with a decreased energy, and then you have another line, and then you have another reflection, and eventually a small fraction of the energy will continue to propagate inside the tissue. However, and then you have maximal reflection coming back from this line of interest. However, if you insonate in an oblique fashion, as you know, the basic rules of physics means that only a small fraction of the reflected beam will eventually come back to your transducer, and a lot of it will be spread outside. These are the basic rules of physics. So if you're insonating not perpendicular but obliquely, you're losing a lot of energy, and eventually you're losing pixels and image quality. And what happens if you're insonating exactly in parallel to any structure or any change in density? You get no reflections at all, and you actually don't get any pixels. So the pixels are just a noise coming from the tissue itself, but it's not exactly along these borders. And this point is very important when we are talking about midbrain, hindbrain, especially when we're talking about early development, because these structures are very, very small at this age. But I will try to convince you that if you're using the correct technique, you will be able to insonate it very nicely. And this brings me back to a point which I pointed already yesterday when I talked about the early screening views. And let's focus a little bit on the vermis. And this is according to evidence-based data. This is a fantastic paper published in Science. And if you look at the mid-sagittal view cut through a specimen of a human vermis, you can see that at 12 gestational week, as I told you yesterday, it is completely smooth. However, at around 14, 15 gestational weeks, the primary and also the secondary fissures of the vermis starts to appear and infold inside, and along these infolds you also have pia mater, and this is this is a phenomenon that does not happen along the walls of the hemisphere, because the folia of the cerebellar hemisphere do not start to fold at 15 weeks as opposed to the early vermian fissures. Now, why is it important? This is important because whenever you're insonating the fissure, you have the folds of the pia, you have a little bit amount of fluid inside, you have a change in tissue density, and these fissures will reflect back to the transducer, something that will happen much in a less significant proportion when you're insonating the hemisphere, or if you are insonating parallel to the fissure. So you're using this property of the early developing vermis as opposed to the early developing hemispheres in order to obtain a good image. Now, recently, we published this paper which describes the normal sonographic development of the midbrain, hindbrain during early second trimester, and I would like to show you some of our findings. So the first thing, as I showed you about the vermis, if you insonate on the coronal image through the posterior fontanelle and you look at the cerebellum, you see that the hemispheres are isoechoic, but however, along the midline, you have these folds of echogenic reflections which represent the vermis. And if you perform a mid-sagittal section through this area, on the mid-sagittal view, you see these tiny reflections along the vermis, which are not present if you're cutting on the parasagittal plane through the hemispheres. As you can see here, it is smooth and isoechoic. So remember this point: if you're insonating correctly, you should be able to visualize the early vermian fissures after 14 gestational weeks, as we showed in our study. Now, how does it look on the live scan? And purposely, I put this video because it's quite an old video. It's a transvaginal probe, but it's a low resolution, normal standard resolution. This is not one of the new fancy transducers. And I would like to show you that if you're performing in a good technique, even the basic transvaginal probes will do the job. You can see very nicely here that when I'm scrolling through the mid-sagittal plane, I will take the image a little bit backwards. You can clearly see these reflections along the midline, and then you're moving a little bit to the parasagittal plane, and then you see only the isoechoic hemispheres here, and you know for sure that the vermis is here. And if you rotate the probe in 90 degrees, you can clearly see the early vermian fissures here along the midline, which you cannot see on the hemisphere. So bear this in mind when you're studying the midbrain, hindbrain. And this phenomena, if we go at 16 weeks, even if you're not exactly on the posterior fontanelle, you're along the superior sagittal sinus, you can still see clearly that between the two hemispheres, you see the echogenic reflections of the vermis, which are not present on the hemispheres. Now, if you go to 14 weeks, you can already see the beginning of the fissures. You can see them clearly when I'm scrolling, even through the anterior fontanelle. You can clearly see the early fissures, which are not present as folia on the hemispheres. However, if you're going to 12 gestational weeks, this is completely isoechoic. You fail to see the primary fissures just because they are not there yet. It's not because you're failing, it's because they are not there, and the echogenicity of the vermis is exactly as it is of the hemisphere, so you cannot really say that you can visualize the early beginning of the vermis. So this is an important clinical point. Now, another point to remember regarding the developmental anatomy, two things. First of all, the mesencephalon is very, very big early in pregnancy during the embryonic period. As you can see here, the walls, the tectum and the tegmentum are still very thin. There are not many fibers there. There are not many cells there. And the lumen, which is the aqueduct, is very, very wide. And another phenomena that you have to remember in the embryonic period is that the brain has a kinking appearance due to this mesencephalic and pontine flexure, these two flexures that gives rise to the Z-shaped appearance, as you can see here, also a 10 weeks embryo on the histological specimens. Now, we aimed to investigate this phenomena. What happens to the Z-shaped brainstem at the beginning of early second trimester? And in order to do that in a mathematical approach, we drew two reference lines, one of them in the ventral tegmentum, and the other one is on the dorsal pons. And we saw that before 14 weeks, and you can see here at 12 weeks, that the pontine line is more anterior to the tegmentum line. And what happens due to the development and change of the structures of the pons and the midbrain, these two lines move in two different directions. And as a result of that, after 14 weeks, the brainstem becomes in its more linear and mature way as you're used to see it later on in pregnancies. And this happened in 100% of our fetuses after 14 weeks. Another important clinical aspect for you to remember is that the aqueduct is very, very large at 12 gestational weeks. However, it decreases in size, as you can see here in these three different age groups. However, remember that although it becomes thinner, it still must be visualized during early second trimester, because in terms of ultrasound, it is still quite big, and you should be able to recognize the fluid inside. And if you fail to recognize the aqueduct, this is either a pathological mesencephalon or you're in the wrong plane. So be very careful on that and study it very carefully. Now, when we go to the classic view, the mid-sagittal view of the brainstem, of the midbrain, hindbrain, during, let's say, 15 weeks here, so clearly we can see in the midbrain, the aqueduct, as I mentioned, the tectal plate, which is thinner ventrally, is dorsally, sorry, and ventrally is the tegmental plate. When you go a little bit lower, this is the protrusion, the normal protrusion of the pons. Behind the pons is the fourth ventricle, and then you can clearly see the vermis with its tiny reflections, which represents the early vermian fissures, as I showed you before. Now, pay attention, please, to this corner-like appearance, corner-like shape here. And I think that if I would ask you, how would you call this corner-like structure? Some of you, most of you will say that this is the fastigum. But however, if you look on the multiplanar imaging on the corresponding coronal image, you can see that the lower part of the corner, what we think is a fastigum, actually is not a part of the vermis. This echogenic reflection results from the choroid plexus of the fourth ventricle, which is lying below the early vermis, giving us the false impression of a normal fastigum. But a vermis at this gestational age, and also as you can see on the histological preparates, there is barely there. There's no fastigum. It's completely straight. So what you think is a fastigum actually is composed, the lower part, the lower leg is composed of the choroid plexus. Also remember this important clinical point, and we saw this in all of our cohort of fetuses. Now, we all mentioned the word Blake and Blake's pouch and Blake's teats. Let's just remind ourselves what is the Blake. So this is from the original publication by Joseph Blake, and you can see this outpouching of the membranes, the inferior membranous area, and we can clearly see it on the ultrasound. You approach from posteriorly, you can see the membrane bulging out below the choroid plexus of the fourth ventricle, and it's like a false physiologic communication with the fourth ventricle. Now, we showed in our study that the patency, this neck of the Blakes, is completely normal after 14 weeks. You should be able to visualize it. And as a result of the vermian development, this orifice, this neck of the Blakes, decreases in size and it becomes closed, and with the normal appearance or normal communication with the foramen of Magendie as a result of normal vermian development. So if you see 15, 16 weeks, a communication, this is not a communication, it's a completely normal physiological anatomy. Now, another important acoustic window that sometimes people forget about is below the foramen magnum, below the occipital bone through the foramen magnum. Let me show you by transvaginal ultrasound. It's quite easy to approach because you're going along the back of the fetus, and then you can rotate, and you can see the lower part of the fourth ventricle, the Blakes, the medulla oblongata, and if you come from low enough, you can also appreciate the lower part of the vermis. So this is another very nice acoustic windows in early pregnancy. Don't forget to use it on your routine scans. However, you need to remember that not all fetuses went to the literature and read the literature. And let me show you this case I just recently saw. I performed the nuchal scan at 11 weeks. And if you look at the midbrain, hindbrain, something is wrong here. Do you see here this line? So I performed also a 3D in order to prove what you see here. And you can actually see that the Blake's pouch is closed. So how do we call it? This is an obliterated Blake. This is an absent Blake. Maybe this is a non-evaginating Blake's. So what's going on here? But however, if you take a close look, you see that the brain is completely normal. There's no ventriculomegaly, so there's no hemodynamic problem with fluid flow. So everything is completely normal, but there is no Blake, or there's no communication with the classical Blake. I told the patient that I think it is nothing because there was nothing else in the fetus, and she came back at 2 weeks later on, at 15 weeks, 3 weeks later on, and this brain is completely completely normal. You can see that these remnants of the membrane disappeared, and you have this normal appearance of the plaque. So this is, again, another example of don't make any false diagnosis at 12 gestational weeks. If the remaining of the brain is normal and there's no ventriculomegaly, just wait and see. Things usually are have a tendency to be okay if this is an only isolated subtle finding during the embryonic period. Now, I would like to show you some cases and to show you examples how different stages or stations along the midbrain hindbrain might become pathologic as compared to the normal images in the normal anatomy that I showed you. And I'm not going to talk about any cystic malformations. And also, I will not go deep into the malformations themselves because you're going to have a very nice talk with Karina about infratentorial malformation. So I will just would like to focus on the sonographic anatomy and to show you that everything is there much earlier than you think if you just make the effort and try to make the diagnosis. This is a patient referred at 16 gestational weeks due to early ventriculomegaly. Now, again, as we talked about the corpus callosum, please don't measure before, because if you measure this, you can say, okay, it's just 10 millimeters, it's borderline ventriculomegaly. And if you play a little bit with the calipers, you might end up here with a 9.7 millimeters. So this is by definition not really ventriculomegaly. However, we know that at 16 gestational weeks, we should have ventricles at around 6, 7, 5 millimeters. And furthermore, if you look at the parasagittal image of the hemisphere, you see it's like it's ballooning up. There's a lot of fluid. There's a little bit thinning of the parenchyma. And most importantly, the choroid plexus are shrinked and dangling. So for us, this is ventriculomegaly. I don't use the calipers. It's 10.8 or 9.7. This is an early ventriculomegaly for sure. Now, we perform the mid-sagittal cut, and you see here, as I told you yesterday, you can see the corpus callosum. It is a little bit lifted up because the laminar unions is being pushed up mechanically speaking, only mechanically speaking. You can see the massa intermedia, the interthalamic adhesion here in the middle of the third ventricle. You can see the lumen of the third ventricle with the more hypoechoic because there's fluid inside. And then you see this ballooning outwards here. Now, what is this ballooning? I published a paper saying that whenever you have a fluid-filled cavity on top of the third ventricle, it's a CVI. But this case is not a CVI. This case is actually a communication between the third ventricle and pushing outwards a small area in the third ventricle, the suprapineal recess. And this is due to the high pressure in the system because distal to this point, something is blocking the drainage along the aqueduct or along the mesencephalon, and as a result, the pressure goes up and it pushes out the suprapineal recess, it pushes up the ventricle, so we have a triventriculomegaly. Now, the question now is, what is the problem? Because supratentorial anatomy is completely normal, except the fact that there is a ventriculomegaly. So now we need to study the midbrain, hindbrain to look for the reason for the aqueductal stenosis or the pathology. And now when we start to investigate what I showed you on the coronal images, we fail to visualize the early Vermian fissure. And this is 15 or 16 weeks, so you must visualize the early Vermian fissures. And let me run you the clip. Even if I'm going on the coronal images back and forth, in and out, we fail to visualize any early Vermian fissures. And on the axial image, you can see this rounded cerebellum without the vallecula, without the dumbbell appearance. And I think now that I show you the images and the constellation with the ventriculomegaly, everyone in the room knows the diagnosis. This is a rhombencephalosynapsis at 16 weeks. It's quite an easy diagnosis when you know what to look for, especially when you have the ventriculomegaly, because some of those cases will have only late appearance ventriculomegaly. Now, the patient was not so sure. She was not confident enough. We told her, okay, come back, please, again at 18 weeks. And at 18 weeks, you see that the cerebellum is small. There is a clear-cut ventriculomegaly. And when we perform an exact mid-sagittal image of the midbrain, hindbrain, you can see here there are no Vermian fissures. There is no vermis because we are crossing exactly through the rhombencephalon, through the cerebellum. So this is a classic appearance of rhombencephalosynapsis. And just let's us all remember that the hypothesis or the rational pathomechanism behind this pathology is that the fact that we have some kind of a midline patterning defect, that as a result of this midline patterning, instead of having two structures on both sides of the midline and a different patterning of the midline, we have the same patterning for both sides, and which comes up with like a hollow cerebellum. And actually, if you think of these pathomechanisms, it quite resembles the one with the holoprosencephaly, and it's not surprising that there's a high correlation between rhombencephalosynapsis and holoprosencephaly. And you can see here also this midline pattern defect in one of the fantastic papers years ago published by Sarnat. And I think that the best paper in the literature regarding fetal rhombencephalosynapsis is the one published by Karina, and I'm sure she's going to talk about it, so I will continue. Now, let me show you a scenario that happened just last week, and you all know it. A colleague sent you a WhatsApp. I saw a case, I need your help. And this is what she's writing me. I just saw a consanguineous couple. They are non-first degree relative, but they are relatives. The patient is obese, so please prepare. She is an obese patient. They have one healthy child at home, but their previous child died at the age of 4 weeks, and the only thing the parents know to tell us is that he had a huge kidneys with a very severe kidney abnormality, and unfortunately he died due to this abnormality. Now, I took an image of my mobile, and I told her, please send me just one image of the brain, because she told me, I think they have now a Blake's pouch cyst. And I told her, send me just one image. And this is the image she showed me. She sent me, you see here, my mobile. And when I saw this anamnesis, together with this image, I already had the diagnosis. I hope all of you also have it. But let me walk through the case, because we called the patient. We told her to come. We want to see her by herself. And let's analyze this image and see exactly the details. So as I told you, the patient is obese. And I was not planning to scan her transabdominally but I knew I'm going to give a talk about it. So I also recorded one video clip transabdominal just to show you the low quality and the low value of transabdominal images, especially in the obese patient. You cannot say anything about this image. So you go to the transvaginal approach, and the first thing the baby is giving you, you should take it. And the first thing this baby was showing us is the kidneys. And as already you can see that this kidney is enlarged. There's a suspicion of small cyst that starts to appear here at the lower pole of the kidney. However, it's not a huge kidney, but something starts to appear here. But we knew that this is not where the money is. The money is in the brain. So it took a while, but it was not very easy because she's severely obese. However, we were able to rotate the head. And let me show you just a small fraction of a clip of the brain. And now that you all see this image, I hope now you have the diagnosis. This is a case of Joubert syndrome. This is one of the ciliopathies. But I would like to take it one step further and to analyze why do we think this is a Joubert. So we took a 3D volume, and let's reconstruct the volume. We will start with the mid-sagittal image. You can see this very unique shape of the fourth ventricle, and you can see that the fastigium is lifted up, almost horizontally aligned and lifted up. Second, you can see here, according to my dot, that I'm exactly along the midline, and you fail to visualize a vermis. So you see this is a very hypoplastic dysgenetic vermis. When you look on the coronal images, you see this down slanting cerebellar hemispheres. And when you perform a reconstructed image exactly on the axial plane view, you come up with this image. And what you see here in this image is the typical molar tooth appearance, which evolves from the long, thick, and elongated superior cerebellar peduncles and the deep interpeduncular fossa here, which gives rise to the molar tooth sign. But you need to look for the molar tooth sign on the axial view and not on the coronal view, which is quite a common mistake. Now, if you, what I did is I went parasagittally just to cut through the superior cerebellar peduncle, and you can see clearly here that it is thick and it is elongated. And if you go to the illustration, you can see that superior cerebellar peduncles should be going upwards. There should not be horizontally aligned, but according to and as a result of the ciliopathy and the Joubert syndrome, you have this configuration. So remember this three multiplanar arrangement, because each and every one of them is characteristic. When next time you see this combination, think of a ciliopathy, think of Joubert. In addition, I find also a small cephalocele here below the occipital bone, which again is part of the phenotype of the ciliopathies. Now, this is another case sent to me by Dr. Waldemar Krzyzowski, a good friend of us from Poland. I think he's also there with you in the audience. and he's a fantastic sonographer. He spent some time with us, he studied with us, and he's doing a brilliant job back home in Poland. And he sent me this case at 14 weeks for consultation. Let me just show you again his images, and you can see this typical appearance of the fastigium, the horizontally aligned lifted fastigium here, the down slanting folia of the hemispheres, of the cerebellar hemispheres at 14 weeks, and this unique shape of the fourth ventricle. This couple, we suspected the Joubert syndrome. They performed a termination of pregnancy. They performed a TRIO-S, and they found that both parents are carriers of two different pathogenic variants in CEP290, which is one of the known ciliopathy causing genes for Joubert syndrome, and that was the diagnosis. It is an autosomal recessive disease, as you all know, and the main problem is the dysfunction of the primary cilium. And the typical the pathognomonic imaging feature is the molar tooth sign, as I showed you, and you will hear a lot more about this from the following speakers. And as you all know, the additional structures involved is the kidneys and also the liver and the eyes and skeletal system. So remember also to look at the eyes in fetuses. Now, another important point I would like to highlight, and this is the level of the screening, is the fourth ventricle. And this is another paper published by Karina, and I'm sure she's going to talk about it, but I would like to show you the implementation of this in early second trimester. So this is the first case I showed you. This is the second case shared in courtesy by Dr. Waldemar Krzyzowski from Poland. And this is a normal variant. And you can see, this is a normal fetus. And you can see here that the shape of the fourth ventricle in normal screening views is like this. It's wide on the lateral and thin on the antero-posterior, just as Dr. Kreiden has showed us all in her wonderful paper. And but however, in early pregnancy, in this case, there was a classic inverted fourth ventricle, but you may also have something in between because of the superior cerebellar peduncles are still within evolution. So even if you see this bizarre fourth ventricle, not the classical square one, you still need to think about it because this phenomena might appear a little bit later on. So bear this in mind. However, in both of these cases, you fail to visualize a completely normal fourth ventricle, and again, as I showed you, because of the superior cerebellar peduncles. Now, let's continue to another station, which is the aqueduct. This is a patient. She's one of our colleagues. She's a pediatrician in our hospital, and she came for a normal routine, a nuchal scan. I performed at 12 weeks. The nuchal was completely normal, but I also performed a transvaginal examination of the brain, and you can see that the brain is completely normal, no ventriculomegaly. Everything looks completely normal, but in Israel, we are doing a complete anatomy scan transvaginal at 15 weeks, so I booked her also for the anatomy scan, and look what happened when she came at 15 weeks, the same patient, just 2 weeks later on, and now she developed a severe ventriculomegaly. You can see the ventricle, you can see the floating, shrinking choroid plexus, and if you look at the aqueduct here, you just fail to visualize the aqueduct, but 2 weeks earlier, the aqueduct was here. You can see it here, you can see it here, you can see that there is no ventriculomegaly, so something happened. And remember that the aqueduct at 12 weeks is very, very rudimentary, it's very early, so you're not expecting it to be completely blocked. However, at 15 weeks, this aqueductal stenosis due to the mesencephalic pathology becomes evident already at 15 weeks. So we didn't have to wait until 22 weeks to diagnose this severe triventriculomegaly. Now, this is another case of a early ventriculomegaly referred at 16 weeks. Again, you can clearly see the ventriculomegaly, wide ventricle, floating, shrinked choroid plexus, thin, stretched brain parenchyma. So now we have to study again the midbrain, hindbrain. Ask yourself, what is the problem with the plumbing problem? Where's the fluid stuck? And we can see here also both on the axial image, but more prominent on the mid-sagittal images, you can see that something here is completely wrong, and it is wrong, and I talked about it already in my screening talk. Something is wrong here in the continuation between the diencephalon and the mesencephalon. So this is some kind of a diencephalic, mesencephalic junction abnormality. You can see here also that the tectum and the tegmentum looks completely abnormal. So something is blocking the flow of the fluid, and it avoids it from going down into the aqueduct. So it gives rise to the early ventriculomegaly. And this finding has already been described 10 years ago by Laurent Guiboy and his group when they saw severe second trimester obstructive ventriculomegaly with various different phenotypes of diencephalic, mesencephalic rhombencephalic differentiation or patterning. You can see here the image from their paper. You can see most of them were diagnosed later on. However, they did have one case at 17 weeks, and this is our case at 15 weeks. Another case, you can see clearly here that we are along the midline. This is the falx, this is the corpus callosum, this is the vermis, but along the midline, there's a patterning defect, a diencephalon, which involves the floor of the third ventricle, the diencephalon, the mesencephalon, and you can see the small amount of fluid in the third ventricle stuck here. It is well visualized at 15 weeks. It was there. It did not appear at 28 weeks. It was already here before. And this is the last case I would like to show you, coming to the end of my talk. This is a 15 weeks that was referred for ventriculomegaly, and these wonderful images were given to me with permission from my dear friend and colleague, Dr. Brusilov, which is also one of the speakers here. And I would like to focus on the findings of the midbrain, hindbrain. However, there were additional findings, and you all heard about this constellation of findings previously in the previous talk, so I will do it briefly. But if we focus at 15 weeks on the midbrain, hindbrain, you can see clearly here the Z-shape appearance, because of this is arrest of the embryonic state, as I showed you at the beginning. So it has a kinking Z-shape appearance. You can see the two cerebellar hemispheres spread apart upwards due to the cerebellar abnormality, and there's obviously ventriculomegaly. There's a agenesis of the corpus callosum. It's just not there. But you can if you look at the cortical rim, at the cortical covering of the hemisphere, you can see this white echogenic rim already also here with the bumpiness along the walls of the lateral ventricles, and you have an involvement of the eyes. And as you all know, this is one of the dystrophlopathies. This is a cobblestone malformation, and we performed the exome sequencing together with Professor Yaron, and it came out to be a mutation in POMGNT2, which is one of the known Walker-Warburg causing genes, and this has been described thoroughly in the past regarding, you spoke about this in the session regarding malformation cortical development. Would like to show you how nicely you can see also the midbrain hindbrain involvement in these cases, in addition to the ventriculomegaly and the cortical plate, already at 15 weeks if you perform the correct anatomic evaluation. So the take-home message is, first of all, when you assess the early midbrain, hindbrain, you have to look at the brain and not only at the fluid. It's not all about cystic or not cystic posterior fossa. When the vermian, you remember that the vermian fissure starts to appear after 14 weeks. The brainstem, as also Daniela mentioned in her talk, starts to become linear in the more mature way after 14, 15 weeks. The aqueduct, although it becomes smaller, it must be visualized during early second trimester. Remember that the normal Blake's pouch and evagination normally closes at around 18 weeks, but I showed you a case in which at the beginning it was obliterated and then it disappeared. And whenever you have an early ventriculomegaly, according to the pattern recognition, not according to the measurements, you must perform a complete neurosonographic assessment. Don't wait until 22 weeks. You can perform it at 15 weeks by transvaginal ultrasound, and in most of the cases, you will be able either to come up with a diagnosis or to reassure the patient. We can keep on following up, and the chances that everything will be okay are greater. So thank you very much again for listening, and looking patiently to the remaining of our talks. Bye-bye.
Thank you so much for showing us such interesting cases. Moving on, next we have Dr. Karina presenting on infratentorial anomalies late in pregnancy.
Hello there. Happy to see you guys again, and I hope you see my slide. Can you only confirm, please? Yes?
Yes, we can see your presentation.
Okay. So we are going to speak about the late diagnosis of the infratentorial abnormalities. We have spoken a little bit about it yesterday, and Rui has brilliant introduced the early diagnosis of these entities. And you see here, when the patient comes, then Rui will be here the first to catch, but sometimes we can't. And then someone needs to be in the back, of course, to take the ball. By this picture, you also understand that I know nothing about baseball because these two guys don't play at the same team, but it was just for you to wake up because I know that you had a very hard day and this talk is going to be a little harder, so we are going to keep going. So a normal second trimester ultrasound does not exclude intracranial structural pathology. We know that from 20 years ago and probably more. What we didn't know and what we are constantly learning more and more are the phenotypes of what are the diseases that we are able to diagnose later on in pregnancy. And I don't have enough time to scrutinize the literature, but there are more and more papers describing what are the late findings that can be observed using ultrasound. And this is a publication from the British group showing that in a routine third trimester ultrasound, an incidental fetal anomaly will be found in 1 in 300 women. But if we check on what are the abnormalities that were diagnosed, remembering this is a basic screen, so they have arachnoid cyst and posterior fossa abnormalities described in a few fetuses only, and we don't see the diagnosis, none of the names that the diagnosis that we are going to discuss in this lecture. So there is much more behind this number, and we need to remember that. So the reason that we diagnose infratentorial abnormality later on in pregnancy can be, the reasons can be many, but mainly either it was present but not seen, okay, such as callosal abnormalities, malformations of cortical development, brainstem abnormalities, Vermian abnormalities with closed fourth ventricle, and other components of abnormal axonal guidance or cortical development. So these are the ones that many times they can be diagnosed if we do an advanced scan, but as we did a basic one, we could not suspect on them. And then our strategies to prevent underdiagnosis will be adding the fourth ventricle plane in axial views, as we have spoken yesterday, adding brainstem planes in order to check for the Moeller 2 sign and other abnormalities that we are going to discuss in this talk. And of course, go mid-sagittal. Okay, so we go one step further, and this will help us diagnose these abnormalities that are already there, but we couldn't check on them. The other reason that we cannot diagnose abnormalities in the second trimester is because they will indeed appear later on in pregnancy. They are either developmental or acquired or neurodegenerative, but they can appear later on in pregnancy. We have a real problem understanding the incidence of these abnormalities during pregnancy. And we are speaking about cerebellar hypoplasia and pontocerebellar hypoplasia, many times associated with supratentorial abnormalities, cerebellar atrophy, many axonal guidance disorders. We speak so much about the malformations of the cortical development. So the core of the neuron getting to the cortex, and we speak less about the axon, which is very, very important and will be responsible for the brain parenchyma and all the connectome of the brain. Insults, tumor, cysts, vascular malformations, and other rare entities. So many abnormalities, and it's quite scary, but this is the reality, may appear only later on in pregnancy, and we must be aware of that. And there is this very, very interesting paper from the group of Catherine Garel in France, then that they described the late appearance of the midbrain, hindbrain abnormalities. And here we see like the Dandy-Walker malformation was diagnosed as expected before the first half of pregnancy. And the Moeller 2 sign, on the other hand, here was diagnosed only in the third trimester, but Roy has showed brilliantly that we have all the tools to do it earlier in pregnancy. But indeed, many of these abnormalities will be present only later on in pregnancy. So, and they state, and it's very, very important, okay? Most of the abnormalities that have associated findings will be diagnosed or suggested earlier in pregnancy. The isolated ones will be more difficult to be diagnosed earlier in pregnancy. And they state on what we have spoken yesterday, the importance to measuring the TCD in every exam, especially later on in pregnancy. Here with a sensitivity of 52%, only measuring the TCD could raise the suspicion of a problem. And this is a very important thing to be taken home. If you forget everything on this lecture, remember to measure the TCD later on in pregnancy. And we are going to start speaking about cerebellar hypoplasia. And again, hypoplasia is a misnomer in this very heterogeneous group of diseases. And although I am the lecturer, but I want to pose a question, as I have the honor to be here together with many exceptional experts in the field, not only in the panel, but also in the audience, because the postnatal literature says that cerebellar hypoplasia is a static diagnosis, atrophy is a progressive diagnosis. But in the fetus, we see it so progressive in many or most of the cases. So the postnatal understanding of some of the abnormalities sometimes can really not be translated into fetal life. And we see these processes so dynamic. So maybe some of the neurologists or the pediatric neuroradiologists want to say a word about this concept of a static status of the cerebellar hypoplasia. Anyway, this is another great paper that described then the fetal and perinatal outcome associated with a small cerebellar diameter. And you can be very surprised, but this is one of a kind paper. There are no papers on this topic, specific on this topic. And okay, what is the cutoff? So we say that cerebellar hypoplasia is a reduced volume of the cerebellum, but what is our cutoff? How reduced is really reduced to enhance the chances of an abnormal neurodevelopmental outcome? So the group from Laurent Guibault had tried to set different cutoffs, -2, smaller than -2.5 standard deviation, between 2 and 2.5, and between and bigger than 2. And they have stated also the associated findings that were highly present whenever the TCD was below the 5th centile, and the smaller the TCD, the higher the prevalence of these abnormalities, either chromosomal, remembering our trisomy 18, but also Down syndrome, okay? Major abnormalities of CNS and other systems, severe IUGR. So IUGR with small cerebellum, please don't say that the cerebellum is small because the fetus is small. There is a significant association of a syndromic and abnormal outcome, and infectious fetopathy. And we remember here the parvovirus that may, especially when it's doing hydrops, will lead to also a reduction in the cerebellar volume, and this is something that we know about. And here, remembering Down syndrome and Edwards syndrome as well. But cerebellar hypoplasia is a quite heterogeneous group of disease. It is like a symptom, like a ventriculomegaly, I can say. So because there are many reasons for that, and most of the reasons will not lead to isolated reduction of the cerebellar volume. So it can be with the Vermian involvement, global reduction, many different causes associated with the malformations of cortical development. And this is quite an interesting chapter from the academic point of view. Cerebellar agenesis associated with other brainstem abnormalities, but not of other parts of the brain. We are going to speak about the relationship between the infratentorial structures and the diencephalon. And of course, the importance on checking on the pons and the pontocerebellar hypoplasias, that is quite heterogeneous as the cerebellar hypoplasias themselves. And here, again, another group, and here I must take the hat off to the very important contribution of the French in different groups to the study of the cerebellum in the fetus and these different topics. We have amazing publications from the group from Laurent and from Catherine and other groups. So really, I recommend this literature. And here they define, because again, we don't have these guidelines for fetuses. We only have guidelines for postnatal population. So what is pontocerebellar hypoplasia? Again, a generic, non-specific term that will be used to describe reductions in the volume of the pons and the cerebellum. Why is it important, either the cerebellar or the pontocerebellar hypoplasia? Because they have a poor prognosis and they have a significant genetic importance and a high risk of recurrence in many cases that we need to diagnose these cases properly whenever we have the opportunity to discuss termination. Depending on the gestational age, we need to do so. So we need to make the effort to diagnose these cases. And the pontocerebellar hypoplasia term was described in 1993 by Peter Barth, and these are the classic pontocerebellar hypoplasias. And here he describes thinning of cerebellar cortex, decreased density of the pontine neurons, fragmented appearance of dentate nuclei, degenerative process starts prenatally, and whenever reading these sentences, the sonographist is already needs resuscitation. Okay, because can we measure the cerebellar cortex using ultrasound? And even by the resolution of the MRI is quite challenging. Can we speak about the density of the pontine neurons? So are we able to diagnose it in pregnancy? We are. And we are going to show you some cases, okay? And these are the classic types, the neurodegenerative types described by Barth. And we know that the different phenotypic presentation, the genotypic correlation of these classic PCH cases. And this is a very interesting case. This patient was referred to us. She was very lucky that the fetus had a small head. Okay, a reduced, smaller than second centile head circumference. And this was the reason that the patient was referred. Okay, but at 26 weeks, you can see that the transcerebellar diameter was 22%, 22nd%, quite okay. Not even close to give us a clue that something is bad. Okay, but the head was small and there was abnormal sulcation, so we continue to check on the patient, and here almost no growth from one to the other exam. But then we have, and this is a post-processing evaluation after we had the diagnosis, and if we check on the morphology of the brainstem and the cerebellum, it's quite kept. Okay, we see the belly of the pons, we see the vermis quite hyperechogenic compared to the pons. We don't see an irregular posterior aspect of the brainstem, nothing, but the biometry is small. The TCD was about the 15th centile, but the biometry of the anteroposterior diameter of the pons and the height of the vermis were small by this gestational age, but we didn't diagnose that because morphology was so good that we didn't measure it then. By 30 weeks, the head was still super small, almost did not grow, and then the TCD got small. Okay, although the anatomy wasn't suggesting that there was a problem. The supratentorium was amazing. Okay, so all of the features you've heard, Daniela, and we can compare, if we can use ultrasound, we can use MRI, whatever method you want, but it's clear cut that we have a very abnormal development of the sulcation, and again, the morphology of the brainstem and the cerebellum are quite kept, but the biometry is small, 28 millimeters at 30 weeks, 8 millimeters anteroposterior diameter of the pons. This is pontocerebellar hypoplasia. But here, although I am against mathematics, against measurements, but these are the groups that will need us to do measurements because the diagnosis will be here. And this is VRK1, a classic PCH1 by Barth. And again, this fetus or this family had the opportunity to choose the destiny of the pregnancy because the malformation of the supratentorium and not the infratentorium. Differential diagnosis of pontocerebellar hypoplasia includes many other diseases because not only the genes and this mechanism of disease that Barth described will affect the development of the pons and the cerebellum, but also association with other cortical malformations, metabolic diseases, the genetic disorders, Walker-Warburg, and isolated midbrain, hindbrain abnormalities, and other disruptions. And here I go back again then to this paper. So they defined that if the anteroposterior diameter of the pons was below the 5th centile, together either with a small TCD or a small Vermian height or a small cerebellar area, then this was the criteria to consider the case, the prenatal case, pontocerebellar hypoplasia. And in their sample, they had classic PCH, which was associated with one of the classic genes. And also they included the CASC gene, which is not classic by Barth. The non-classic PCH that had other variants that are not classic, the chromosomal PCH, remember the trisomy 18, and among them, and other types. So they have classified into 4 types. What is very, very interesting that if you see the postnatal imaging of pontocerebellar hypoplasia, the imaging is very, very abnormal and severe. And during fetal life, in many cases, the morphology is still quite kept. Okay, so this is another take-home message. Do measure. Here is easier, okay? But here and here and here, it can be quite challenging. It's very rare that we see a coronal view of the dragonfly, which is the classic postnatal view of the many types of pontocerebellar hypoplasia. But see here, the coronal views in many cases is not quite informative in the fetus. Okay, so here is another case, again, a frightening one. This is 29 weeks. Cerebellum is very, very small, but morphologically very nice. Cisterna magna not enlarged, but the TCD below the 2nd centile. Sagittals look good, but biometrically small, and this is a CASC gene-related PCH, okay, which is X-linked abnormality, commonly affecting females because they are little in males, and they have the postnatal dragonfly, okay, but our patient is very far away from bringing dragonfly during fetal life, and we need to remember that. Okay, sometimes we have genes that are quite significant. So this is the PTF1A variant that comes with the vanishing cerebellum or the cerebellar agenesis. You see here, you look into the fossa and you see an empty fossa. This is quite characteristic, okay, of this gene, we must remember, but most cases of PCH, remember, are not like that. Another very interesting chapter is when the cerebellum and the brainstem are abnormal together with the supratentorium, so generalized abnormalities. And the main group that is involved in brainstem abnormalities are the lissencephalies. Okay, and we know that LIS1 less, so in Miller-Dieker we don't see significant involvement of the brainstem and the cerebellum, but in ARX, if you remember my talk, Relin and other abnormalities, so we may have, again, postnatally, much more significantly than prenatal evaluation. But there is always a but. What you see is what you get. So I don't have a lot of time to have you look into this picture, but the ones that see the young lady or the old lady, normally we see only one. Let's see if you see them both in this case. So the patient was referred 24 weeks, a male fetus with a huge head, okay? Head circumference 3.5. Automatically, we open the drawer of the overgrowth syndromes and the overgrowth of the brain, and then we try to look for mTOR pathway findings, and we find a very abnormally developed sulcation, a huge head, ventriculomegaly, irregular ventricular walls, and whatnot. So you see, it's like, price. Okay, I can even say the gene, this is PIK3 or whatever. And then it's like, for us, at 24 weeks doing this type of diagnosis, even telling the gene is quite a conquest. The fetus had a coarse facies, had even beefy thumb and abnormal fingers. This is quite suggestive of an mTOR pathway abnormality. The sagittal views showed also abnormal corpus callosum and a very, very weird brainstem and cerebellum that we have a little bit overlooked. And then we said, okay, it really compatible to megalencephaly polymicrogyria, and we did check, and we quite little overlooked our brainstem. The pregnancy was terminated. The pathologist, megalencephaly polydactylia, so, okay, we took the ball, like our first slide. But then comes Yuval with the diagnosis of the exome. And he says, okay, this is Joubert 10, ciliopathy. What? Ciliopathy. So how can a ciliopathy be related to this phenotype? Because we cannot understand the relation. But then we go back to what we have overlooked, and we see our molar tooth here. Okay, here, but Karina, you wrote the paper. Did you overlook? Okay. We wrote this finding in our report, but we didn't give the proper attention. If we go coronal, we see the downslanting cerebellar hemispheres. So this is Joubert, okay, or Joubert feature. Everything else is not important, but this is a Joubert feature. Do not ignore it. Okay, and we understand that in OFD-related disorders that are ciliopathy, we can have also macrocephaly and components of overgrowth syndrome because the OFD and the mTOR pathway may meet somewhere in the middle, but together with these Joubert syndrome findings. So the answer for the diagnosis is in the brainstem and not in the supratentorium in this case, and it's not lissencephaly, it's overgrowth brain. Another problem is the axons. So sometimes the malformations of cortical development are prevalent, and sometimes we have problem with the white matter and the connectivity. And here we have corpus callosum agenesis, L1 syndrome, here our guy Joubert, tubulinopathies between other differential diagnosis, and we have genes that we know that are related, but our baby is the tubulinopathies, as in the last decade we have learned a lot about it. There are many good papers on that, and as Gustavo said before, the postnatal impression of tubulinopathies was a little different from what we see in the fetus. We know that the tubulinopathies will affect significantly the brainstem and the cerebellum in almost all genes. And we learn from the aspects of the MRI what we need to go back to ultrasound and check. So here we understood, okay, tubulinopathies, among many things, makes the brain look asymmetric and makes the brainstem look asymmetric. Can I see this using ultrasound? And the answer is yes. And here is a recent publication together with the group of Catherine Garel showing neurosonographic and MRI criteria. And for a suspected tubulinopathies, but we understand that there are mostly two phenotypes, the more severe like TUB-A1A and the milder ones like TUB-BB3. And in many cases in the fetus, we have normal transcerebellar diameter, and we still don't have microcephaly in the fetus. Postnatally, we have microcephaly, but prenatally, we do not. So here we have the cases of TUB-BB3, and you see the asymmetry, axial view, asymmetry of the brainstem. We can see the asymmetry of the brainstem. We can see the irregular interhemispheric fissure, and we can see the asymmetry of the basal ganglia as well, and the typical shape of the anterior horns. This is, again, TUB-BB3, TUB-A1A, and this feature is quite reproducible either using ultrasound or MRI if you know how to look at it. Again, either ultrasound, either MRI, the features are described. In TUB-BB3, the brainstem cerebellar findings will be milder in the fetus, and in TUB-A1A will be more severe. What else can we find later on in pregnancy? And this is an interesting case. This is not a very, very advanced disease, but it's a very advanced pregnancy, but it's a very rare disease, presenting with cerebellar hypoplasia, very small cerebellum. And then this is a patient that we kindly got from Michelle Fink and Richard Leventer from Australia. Then they sent to MRI, and here we see a bulge in the posterior aspect of the pons, like the belly of the pons came to the back. Okay, so this is a cap. The cap may be located at the level of the pons or at the level of the medulla, and we call it either pontine or tegmental cap dysplasias. So these are part of the cranial neuropathies, and they will affect the nerves, the nuclei and the cranial nerves, and they will have ocular, speech, and movement abnormalities, and they may have quite a bad prognosis. So remembering, then checking also how does this pons looks in its posterior aspect. This is a very rare case that we had the opportunity to describe it. I think the second case in the literature, this is a mass protruding posteriorly from the cerebellum.
Karina,
Just very
Karina,
hard.
we are running
Yes.
short of time. If you can
Okay,
finish by
2
in
minutes?
1 minute. Thank
Okay.
you. Okay, should be fine.
Good. So here we have the protrusion in the posterior aspect of the medulla. Okay, so the mass didn't come from the cerebellum, but either from the medulla, and this is a medullary cap dysplasia. And together with friends from other countries, we had the opportunity to describe a case series and even some related genes. And the main differential diagnosis of the masses coming from the midbrain, hindbrain structures may be tumors. And this is an opportunity to present this wonderful work made by Rashna Gupta on a gangliocytoma of the cerebellum, a mass protruding from the cerebellum. The patient was sent because of an open fourth ventricle. Okay, so the mass distorted the cerebellum and raised the vermis. And we even have a tubulinopathy pattern of the anterior horns, but the pathology showed that it was a tumor, a Lermite-Duclos disease, a gangliocytoma of the cerebellum. And I will just end with this slide. Unfortunately, we don't have more time, but severe ventriculomegaly, or either ventriculomegaly, new ventriculomegaly appearing later on in pregnancy, we must remember that sometimes the answer will be at the level of the diencephalic and the mesencephalic differentiation. And we need to have a close look at the level of the third ventricle, thalami, aqueduct, and cerebellum in order to be able to diagnose the abnormalities that involve the diencephalic and mesencephalic junction dysplasia. It was described also by the group of Professor Dobbins, also from the group from Professor Guibault, and also from the group of the Italians, Marisavina Severino. They described the butterfly sign at the level of the encephalon for type A. Then Severino classified into two groups, and in the type B, we see a continuity between strings connecting the diencephalon and the mesencephalon. And here we can show the features either using ultrasound with the butterfly sign, either using MRI. And here we see the strings of fusion between the diencephalic, the massa intermedia, and the midbrain structures in type B. And this is the classic severe phenotype that we see early in pregnancy in L1-CAM fetuses. So I thank you so much for the attention, and I'll be happy to answer questions.
It's okay. Yes, it's a wonderful presentation. It's a little bit complicated, but I think that basic things that you should remind is that the fact that the TCD, you like the rules, is equal to the number of gestational age, of weeks of the gestational age, till 24 weeks, and after there is an increase of the TCD. And when this is why the PCH involve the fact that there is a proliferation in the second part of the pregnancy after the 6 months of pregnancy. So when you do your ultrasound at the second trimester, all is normal. And if you have a case, an index case in the family of hypoplasia of the cerebellum, you should do ultrasound around 28 to see if the TCD is 32. In our experience, each time we have an index case of cerebellar hypoplasia or pontocerebellar hypoplasia, we should do a control, a follow-up at 28 to be sure that the expansion is doing well.
Thank you very much, Laurent. We have a great pleasure to introduce Professor William Dobbin, and I'll hand over the mic to Gustavo to introduce him.
Okay, I think that currently I don't need to introduce you, Bill, because in every lecture that was presented regarding fetal anomalies, your name appears there. So you recognize your fantastic work. You are probably one of the kings or the emirs of prenatal diagnosis of congenital anomalies, and it's a really big pleasure to have you with us.
Thank you. Can you hear me?
Yes, we can hear you.
Good. Well, Gustavo, thank you very much. It's certainly a pleasure to speak to this group. I'm sorry I couldn't get all the way to India, but in my view, fetal medicine is one of the most important new developing areas of medicine, and I've been thinking about it quite a lot. So let me start by sharing screen here. So first, I did want to thank Dr. Acharya and Malinger for the invitation to speak to you today. Let's see, share screen. It should be, which one do I want? I think this one, and then share screen. No, get slideshow, and there we go. Can you see the screen? Can everybody see this now?
Yes, we can see your screen, please.
All right, and so this should be the screen with just the slides. I think that's
Perfect.
correct.
That's perfect.
All
That is
right, so
perfect. Correct.
I know that we are running a little late, so I will be efficient in talking here. So I'm going to review the genetic basis of cerebellar malformations, but in addition to that, I'm going to be talking about the non-genetic causes of cerebellar malformations, which I think may be as important or even more important than the genetic causes, and learning how to recognize and differentiate these. Some of these same rules apply to the cerebral cortex as well. So Dr. Yaron already showed one of these papers. So these are two papers published in 2019. The one on the right from my lab, and I'll talk about that later. The one on the left from Dr. Kathy Millen's lab, who I worked with for many, many years. And what this paper did was to completely change our understanding of cerebellar development in humans. Here's the key figure, which Dr. Yaron also showed. What this shows is through the first third of pregnancy, most of the cells in the cerebellum, all of the granule cells and a few other types come from a small little tail-like structure at the lower end of the cerebellum called the rhombic lip, shown with small black arrowheads. And at 13 post-conceptual weeks, I've made it a big black arrowhead. In all other mammals, including lower primates, especially the macaque, the rhombic lip disappears about 1/3 of the way through pregnancy. And that was the accepted development for humans as well until this paper. And here, what this shows is between 13 and 14 post-conceptual weeks, the rhombic lip does not disappear, but rather becomes internalized into the lower cerebellum, in particular, the lower portion of the posterior lobe of the cerebellum. And it persists till almost term. And so one of the problems I and Dr. Millen had for many years was trying to understand why the posterior vermis was most severely and consistently affected in cerebellar malformations, because that was not the case in mouse models. And we believe that this is the reason. And so what we have then in the normal human, either on the fetus or postnatally, the cerebellum develops really 9 separate lobules, which all have names. And the lobules that we need to be most focused on, because they're so important in the human, not in monkeys, but in the human, are 7, 8, and 9, the paramus, the uvula, and the nodulus. All right, and I think there are specific reasons why they are more commonly affected in humans. All right, so the next paper, I don't know whether you've discussed this or not, but there are 2 papers, and the first author is Dr. Matthew Whitehead, in which he defines additional criteria for classic Dandy-Walker malformation and the Blake pouch cyst. I'm not going to talk about Blake pouch cyst today because we know so little about the cause. But Dandy-Walker is important, and I have had difficulty recognizing which to call Dandy-Walker until just the last couple of years. And these features, so here is so what they're focusing on then is the choroid plexus of the posterior fossa and the adjacent connected structures known as the tinea and the tila choroidea, or TTC. And so the TTC and the choroid plexus comprise the lower part of the roof of the 4th ventricle. And when they can be seen, especially on MRIs, both fetal and postnatal, their position can help to differentiate between classic Dandy-Walker, Blake's pouch cyst. And here is the example where on a postnatal scan, where it's easier to see, you can see where it's pushed far, far downward and outward. All right. So it is easier now to recognize and define classic Dandy-Walker malformation. And this definition is really important both for the genetics and for the developmental outcome. The other important sign to recognize this was first reported a couple of years ago by Silvia Bernardo and colleagues from Rome. What they recognized was an unpaired caudal lobule, which I think I can circle here, which they called, and I call now, a Dandy-Walker tail. When this is present, it is almost always a classic Dandy-Walker malformation, and I see these in at least 80% of Dandy-Walker. All right, so I have defined several groups of cerebellar malformations, and you've already heard about some of these. What are the important differences? In the last talk, Christina talked about pontocerebellar hypoplasia and how the term didn't really fit because often there were problems well before birth with progressive atrophy. In my writings, I'm going to stop calling the classic PCH, and call it prenatal onset pontocerebellar atrophy. I think this has been a confusing term to try to, and so that diffuse cerebellar hypoplasia and the classic butterfly pontocerebellar hypoplasias are too often confused. And too many times I've seen other physicians order the wrong genetic testing because the description was too confusing. All right, why do I talk about these groups? So the difference is because the results of genetic testing are different. In diffuse cerebellar hypoplasia, the yield of genetic testing is high. In a series of 5 overlapping common cerebellar malformations, at least 4 common, cerebellar agenesis is not common, but there's a combination. My data shows a combination of genetic and especially non-genetic causes of these malformations. And differentiating makes an important difference in terms of what the recurrence risk is, but also it makes a big difference in the developmental outcome. All right, so then on the right side, there are some genetic disorders. You've also heard about these. They're rare, but they're always genetic, okay? And the outcome is almost always developmentally poor. All right, so these are the important groups of cerebellar malformations that I see and recognize. There are, of course, other much rare disorders. I'm going to skip this because you've already seen so many of them. All right, so in the other paper from 2019, the one from my laboratory, we studied whole exome sequencing in 100 probands with mostly common cerebellar malformations. In most of these, we were able to study the parents as well, I think in more than 90. In a couple, we only had the proband. So in this series, I had 43 that using the most current diagnostic criteria I called classic Dandy-Walker malformation, and the others were common cerebellar malformations. I excluded Joubert syndrome and prenatal onset pontocerebellar atrophy, or the Barth group, when I could, although a couple snuck in that I had misrecognized. Importantly, we looked carefully over the histories and the brain scans and identified prenatal risk factors. We were able to solve 36 of these, so 36 out of 100. That yield is very similar to the yield that Dr. Yaron mentioned about an hour ago. All right, so here are the genes we reported in the paper in 2019, and there were about I think 27 or 28 different genes, but that number is constantly growing larger. So there is no good targeted panel. All right, here's one example, and you were shown examples of one patient with CASC a moment ago, but here are 4 females in pink with diffuse cerebellar hypoplasia, and only rarely does this look like a butterfly to me. Most of them do not. On the lower right, I actually have 2 males with CASC mutations, and they're very, very severe. And most of them, as you were told, do not survive. All right, so here's the most important point. There are the panel, the set of genes associated with cerebellar malformations and brainstem malformations is very poorly defined, and it's rapidly growing. So just as Dr. Yaron said, I do not recommend a targeted panel, but I recommend whole exome or even better genome sequencing whenever possible. All right, so what's the data here? This is the yield. And so what I wanted to show you here is, so what is cerebellar hypoplasia? In cerebellar hypoplasia here, I'm including diffuse cerebellar hypoplasia, vermis predominant cerebellar hypoplasia, which is a very human malformation, megacisterna magna with or without cerebellar hypoplasia, and megacisterna magna alone. And then comparing that to classic Dandy-Walker malformation. What I want you to see here is that the diagnostic rate, that's GDX, is very different. with all these other common cerebellar malformations, our diagnostic yield was, we made a diagnosis in 29 out of 57 probands. That's 51%. That is as high a diagnostic yield as you are going to find for any phenotype in medicine. But compare that to classic Dandy-Walker malformation. We found a genetic diagnosis is only 7 out of 43. That's 16%. So 16% is certainly a useful yield, but look how much lower it is compared to these other cerebellar malformations. So something different is going on. What is that? Understanding that is very important to understanding cerebellar development, cerebellar malformations, both the genetics and the developmental outcomes. All right, here, there we go. I'm just emphasizing the key data. All right, and so what I was able to identify by spending a lot of time going through 100 brain scans and all of the clinical data were this. There are several important prenatal mechanisms or causes of cerebellar abnormalities, and you can recognize them sometimes by history, and more importantly for you all, sometimes by patterns on the brain MRI and possibly on prenatal ultrasound. So what are these? First is prematurity, but especially extreme prematurity, 22 to 27 weeks. Second is intracranial hemorrhage. You've already heard about that. Third, twinning and other multiple births. And fourth would be defects of vasculogenesis, development of the intracranial vasculature. You've probably not heard much of that, and there is not that much data because appropriate MRAs are too often not performed. There are some potential prenatal mechanisms, maternal high blood pressure and certain medications, and then viruses. And you've heard about some of these viruses before. All right, here are the other really important patterns that I spent, over a year trying to define as we prepared this paper. Here are the 3 patterns that are associated with a low yield from genetic testing, often a very low yield, which suggests that maybe these are not genetic. 1, cerebellar hypoplasias or Dandy-Walker malformation with asymmetry of the cerebellar hemispheres, not subtle asymmetry, but obvious, severe asymmetry. Next would be cerebellar clefts. And third is perhaps the most important one that you may not have heard of before. It's cerebral heterotopia, mostly periventricular nodular heterotopia, but also subcortical heterotopia. The yield from genetic testing when you have a cerebellar malformation and heterotopia is very, very low. All right, here's an example. So problems with development and injury to cerebellar white matter are well known with extreme prematurity, but my series of 100 had 3 individuals with frank cerebellar malformation or possibly prenatal cerebellar atrophy. But it has been shown in the literature as well. And here's one example of asymmetric cerebellar hypoplasia in a child born extremely prematurely. Here's another example. This is one from Pacheco et al. In, I think, Genoa, but I can't see. They show a baby with a common, a vermis predominant cerebellar hypoplasia prenatally and at, I think, 5 days of age. And blood can be seen in the cerebellum. That's easiest in image G here. But importantly, a repeat brain scan was done at 1 year of age and showed that what looked like a typical, cerebellar vermis hypoplasia converted to a classic Dandy-Walker malformation. So this is important. When published, this was thought to be a rare exception to the rule, but I don't think so. I think this is a common cause of classic Dandy-Walker malformation. Here, the next is twins. So here are my series included 12 twins, which surprised me as well. Here are 2 of them, identical twin sisters from Minnesota, the little girl on the left. These were monozygotic or identical twin sisters. The girl on the left in the yellow, right in the yellow jumper has classic Dandy-Walker malformation. Her sister's normal. All right, so when you combine both our prenatal risk factors from history, and the only two I could be certain of were extreme prematurity and twinning, and the brain MRI imaging patterns. Our yield was only 3 out of 33, or 9%. When we excluded, when we looked at those children who did not have any of these prenatal risk factors, the yield was 33 out of 67, or almost 50%, which is very high. In just the twins and extreme prematures, there was a difference between in the genetic diagnostic yield, but our numbers were too small for significance. But remarkably, when we look at those 3 brain MRI patterns, remember that's cerebellar hemisphere asymmetry, cerebral clefts, and any cerebral heterotopia, the difference was dramatic. When we found only 1 genetic diagnosis out of 24 for 4%, compared to all of the others, in whom the diagnostic rate was almost 50%. The difference here is highly significant. And it was true for each one of these. So here, there we go. Now I'm showing them. All right, so here we show the individual malformations that I found to be associated with a low genetic diagnostic rate. And that suggests to me that most of these are probably not genetic, associated with some of the causes I mentioned a moment ago. So with just severe asymmetry of the cerebellar hemispheres, we had a dramatic difference, a much, much lower genetic diagnostic rate, suggesting that most of them are not genetic. The same is true for clefts, but we only had a few of them. With any cerebral heterotopia, perhaps the most important data I'll give you today, there was a highly significant difference. We found a genetic diagnosis in none, 0 of the 15 patients with cerebellar malformations and heterotopia, compared to all the others where the diagnostic rate was 42%. So significant differences here. All right, so let's go back to some of these patterns. So what we found then was that when you see diffuse cerebellar hypoplasia, it is often genetic. Perhaps the most common gene for this would be the CASK gene, but there are many others. The non-genetic and genetic causes, so the next 5 of them can all be associated with genetic abnormalities, but the diagnostic rate is low. And importantly, these are the most common cerebellar malformations seen both prenatally and postnatally. We have no idea what the genetic the causes of Blake's pouch cyst are at this point. All right, some other malformations are uniformly genetic. And you were shown these in the last talk. The cobblestones, the molar tooth malformations or Joubert syndrome, the prenatal onset pontocerebellar atrophies, and the tubulonopathies are the most common. For rhombencephalous synapses, we have been looking. Some rare RES variants are known to be genetic. I think it's the MN1 gene, but that's extremely rare. For classic RES, we've studied exome sequencing in more than 100 individuals and have nothing to show for it. All right, and with that, I'll go back here. So here, I'm going to end and just point out that that there are really significant differences in the genetic yield and the outcome when you separate these out based on the pattern. So one of the keys is the cerebral hemispheres involved, and is it genetic or not? And I'll address that in the next talk. Let me stop there and end the show and see if there are questions, or if you want me to go on to the next.
Sir, you can continue to your next talk.
Go ahead with the next one.
Yes, sir.
All right, I
Living
have
with
that up.
cerebellar and brainstem animals.
All right, so I have that somewhere. Let me go see. I thought I had it right up on the screen, then things got hidden. Oh dear, where did it go? All right, I'm going to have to go and find it. I know right where it is. I had this prepared just before giving the first talk. It is There we go. All right, so I need to, end of show, that was my problem. All right, so this one I need to close and this one I need to open. Okay, I should be up. Can you see this?
Yes, sir.
All right, so this will be a little bit shorter. I only want to make a few points here. All right, so what's the developmental outcome in birth defects of the cerebellum? So the key here is defining first whether the cerebral hemispheres are involved or not, and second, whether it's a genetic disorder or not. It makes a big difference. So the developmental outcome of cerebellum malformations has been studied for many decades, but usually focused on Dandy-Walker malformations seen by neurosurgery. And so most of the Dandy-Walker malformations seen by neurosurgery because of ascertainment bias are really Dandy-Walker malformation. And I started with that data many, many years ago, and I want to show it to you because of how it compares. So here, in neurosurgical series, of course, hydrocephalus, severe hydrocephalus is very frequent because of ascertainment bias. And other severe outcomes also appear to me more different, more severe. More recent data includes referrals and series from other sources, from genetics and neurology, and especially from fetal medicine. But here is the data from neurosurgery. So the features of children with Dandy-Walker reported in the 80s and 90s and before were large head size and hydrocephalus being very common, high early mortality of about 25%, obstructive hydrocephalus in 80 to 90%, that's neurosurgery, apnea, intellectual disability, and other problems. Here is the data from 6 series from 1980 through 1995. And what I wanted to point out here is even in this series from neurosurgery from many decades ago, the rate of normal or near normal intellectual outcome was almost 50%. Now, others were more severe and often died or had severe developmental outcomes with only a few in the middle, but almost half had normal developmental outcome. All right, so what do we expect to see in developmental outcome with cerebellum malformations? The first of the 2 important issues are the cerebral hemispheres involved? When they are, you would expect a high risk for intellectual disability, epilepsy, and spasticity or cerebral palsy, along with a variety of behavioral and learning problems as I outlined below. But what is it with the cerebellum? When only the cerebellum is affected, what do you expect to get? Well, sometimes those children are normal, unexpectedly, but more often, they have what is called the cerebellar cognitive affective syndrome. This syndrome was first defined by doctors Jeremy Schmemann and Janet Sherman from Massachusetts General Hospital in this important paper published in Brain in 1998. Their data came mostly from adults, mostly adults with either brain cancers or brain injuries. But they do have a few with developmental disorders. And over the years, it has become apparent that individuals with cerebellum malformations are also at risk for the cerebellar cognitive affective syndrome, which consists of the 4 features here: impaired executive function, visual spatial processing, certain specific language defects, and affective or mood dysregulation. In more detail, you'll get deficits in motor planning, difficulty in being able to shift your view or thinking on a topic, difficulty in shifting sets, difficulty with abstract reasoning and working memory. Next, visual spatial processing is very difficult. So people are unable to draw diagrams. The classic way is to have them draw a diagram of a clock, and they're really unable to do so. The language difficulties are often speech lacking grammar and rhythm. Affective disorders are very prominent and include anxiety, depression, and a variety of personality changes, such as blunting of affect and disinhibited behaviors. And in addition, not that I didn't list here, attention deficit is very common. All right, so here is then what you would expect. And individuals who have both cerebral and cerebellar involvement should be at risk for both of these. But of course, if there is severe intellectual disability, you will not be able to see the cerebellar cognitive problems. All right, going back to our study, I've already talked about this, the cerebellar hypoplasias and the Dandy-Walker malformation and the risk factors. So I've already talked about these risk factors again a moment ago. So here, the other thing that I did with these children is divide them. I did not have formal IQ tests except for a very few of them, but I was able to judge whether they were normal or near normal. If they were normal or near normal, they were in regular school or holding a job. And if they were in regular school with a little special help, but still attending regular classes, I called them near normal or high functioning. The others were low functioning, meant that, of course, that they were unable to go to regular classes. They were in special education or often severely disabled or unable to work. So we did have more high functioning than low functioning, but the difference here is important. Here, all right. So what we showed was that in Dandy-Walker malformation, supposed to be the classic severe cerebellar malformation, normal or near normal developmental outcome was seen in 17 out of 43 or 46%. Note how close that is to the neurosurgical data. I think that's very, very important. Compare that to the other forms of cerebellar hypoplasia, where we had only 9 with normal or near normal intellectual development out of 57 for a rate of only 16%, much, much lower. All right, so that's just from the pattern of brain imaging. Next, what happens when you go to genetic diagnosis? And this should not be a surprise. When we made a genetic diagnosis, we had normal or near normal developmental outcome in 1 individual out of 36, or 3%. That young woman is in college and has a rare form of Noonan syndrome, a rasopathy. I think the gene was PPP1CB, if I recall. All of the others were significantly handicapped. So that should be no surprise. Now, if we did not make a genetic diagnosis, what was the yield? Well, we found a normal or near normal development in 25 out of 64, or 42%. And so, how do you counsel when you see cerebellar abnormalities prenatally or early postnatally? And here, I think, are the answers. So 1, if you have classic Dandy-Walker malformation, the likelihood of a good developmental outcome is much higher, particularly if you do not see hydrocephalus and if the genetic testing is normal. Once again, then when genetic testing is normal, that needs to be really exome sequencing and perhaps a chromosome microarray, although, as you were told recently, I think by Dr. Yaron, the yield from chromosome microarrays is low. It's 10% or so, but it's actually even lower with cerebellar malformations. All right, so there's the key data that I'm talking about here. All right, so what do we have then? Of the cerebellar patterns that I've recognized here with always genetic causes, the developmental outcome with diffuse cerebellar hypoplasia, Joubert syndrome, the Barth types of PPCA or pontocerebellar hypoplasia, tubulopathies, cobblestone malformations, it's always poor. Sometimes it's extremely poor, sometimes but they're typically, severely intellectually disabled or worse. Compare that to the more common cerebellar malformations, complete cerebellar agenesis, vermis predominant cerebellar hypoplasia with or without an enlarged cisterna magna, classic Dandy-Walker, and megacisterna magna alone. Those patterns are associated with a much better chance for a good developmental outcome, particularly when the cerebral hemispheres look like they're normal. And then importantly, looking at genetic testing. And so by the combination of looking for the specific pattern on the brain imaging, the presence of those three imaging factors, which make a better prognosis more likely, that's cerebellar asymmetry, cerebellar clefts, and remarkably, cerebral heterotopia. Those are all important to recognize these patterns because they are associated with a more variable and often better developmental outcome. And then genetic testing. No surprise, positive genetic testing is associated with a much worse developmental outcome. Let's see there, and I think those are the key. Yes, so really this is the same message. The genetic forms seen on the right have a worse developmental outcome. They need more common types that can be either caused by either genetic or more commonly non-genetic factors. And with that, I will stop and try to end the show. I need to find my mouse for this. There we go. Stop sharing and show. Can you see me again? Am I back?
Thank you, sir. Thank you for this elaborated talk. Any questions for sir?
Bill, I have a question. Did you make a when you call these conditions Dandy Walker? Did you make a differentiation between there was only what you call Dandy Walker with those that have associated anomalies? But it's clear that from the old papers, they used to call Dandy Walker everything that was a cystic process in the posterior fossa. And the 50% of the cases that are doing normal or almost normal are most probably those that have a cystic process that make pressure, but there is not a congenital anomaly. It's a cyst that is larger than the Black's pouch and didn't disappear. I don't agree with what you wrote about the position of the choroid plexus regarding the differentiation between Black's pouch and Dandy Walker. Always the choroid plexus is outside the cyst. In Dandy Walker is outside the cyst, and in Black's pouch is outside the cyst. So if you have an isolated cyst in the posterior fossa, whatever you call, everything is okay. The prognosis will be probably better than you have also cleft lip and palate, renal agenesis, and four hands.
Yes, so I agree. So some of the ways that the other information you're using about multiple anomalies also is very important. And when there are other anomalies, it certainly increases the likelihood of a genetic diagnosis. So I think we're saying mostly the same things by looking at it in somewhat different ways.
Thank you.
Thank you, sir. Now.
All right, thank you.
Now I would like to call upon Dr. B.S. Ramamurthy, sir, for the rare anomalies of posterior cranial fossa. Over to you, sir.
The first thing I should say that it's no longer rare. We've heard Dr. Karina, we've heard Dr. Rui actually taking us through all these, the spectrum of the PCF anomalies. I'll just do a little bit of pattern recognition. Dr. Rui talked about early diagnosis. I'm going to talk about the classical mid-trimester anomaly scan diagnosis that we are used to in day-to-day life. Okay, so that's what we are trying to cover, but I'll go fast. I know I'm standing between you and a wonderful evening, so let's get down to business. We all know what Joubert syndrome is, but what we need to understand is the sine qua non of the diagnosis is the molar tooth sign. Without the molar tooth sign, no diagnosis of Joubert syndrome. But you have, that's the pure form of Joubert syndrome, but you have Joubert syndrome plus, which means you might have a renal, skeletal, liver, or ophthalmic problem associated with the molar tooth sign, and you will see the overlap and the number of combinations which can come in together to form this one syndrome called Joubert syndrome umbrella. So straight away onto imaging, you have axial transcerebellar, mid-sagittal, or axial via midbrain, coronal, so on and so forth. And outside of the brain, you've got to look at other structures targetedly. And the first thing I'm going to do is to take you straight away to axial transcerebellar. Now, this is normal. This is abnormal. What's the difference between the two cerebellar pictures? Quickly. In the second one, what is missing? The vermis is missing, and what's happening to the two hemispheres? They are touching each other, and that is the kissing hemisphere sign. So the grip of the dumbbell is gone, and you have the two hemispheres are touching each other, and also the fact that the normal fourth ventricle is lateral more than AP, whereas the fourth ventricle here is AP long and lateral thin, right? So that's one way a Joubert syndrome can present in the transverse or the basic plane, axial transcerebellar plane, right? Now, you move and recognize in the same plane, if you just rotate it, you will see that that long fourth ventricle that we spoke of is actually flanked by two structures which are long, which are parallel, and which are actually more horizontal than they should be. What are these? That is the superior cerebellar peduncles, right? And those form the roots of the molar tooth. The mesencephalon itself forms the body, and the thalami actually give you the appearance of the crown of the tooth, and this is the MR picture showing you very elegantly. So hitherto we were believing that molar tooth sign only on MRI, but no, it's written all over. You just have to look at it, keeping in mind the molar tooth sign, and I'm sure you will be able to pick it up. And again, look at the kissing hemispheres out over here. So oftentimes the fourth ventricle is described as being cigar shaped. That's the molar tooth that you have there. And that's the molar tooth of the same case on MR, right? Now, this is important, the mid-sagittal, Dr. Rui actually spoke to us about it. You have the normal here, you have the abnormal here, the normal versus abnormal. Now, in this case, we saw the two hemispheres touching each other. So if I go midline, what is the posterior fossa organ that you're going to cut? It will be one of the hemispheres, isn't it? You can't call it vermis because we've already seen on the axial view. So I'm not going to call this the vermis. This is abnormal. This is the midline cerebellum. That is all I will say. And look at the difference. If it's a true vermis, you have fissures. It lights up like a light bulb. That's how hyperechoic it is. But if it is a midline cerebellum, you don't have the hyperechogenicity because it's folia and not fissures. So you have to distinguish between fissures in the true vermis versus folia in the hemispheres. Also, the fact that the kidney bean shape and the fastigium is seen here, whereas this is a more C-shaped structure, a dome-shaped roof of the fourth ventricle, and lack of a distinct fastigium, right? This is the signature which can happen in one set of presentation, right? And I've brought it all together over here, showing you the MR picture, again C-shaped over here. And then, of course, this also had hyperechoic kidneys, and therefore it's not pure Joubert, it is Joubert syndrome plus kidneys, and this is nephronophthisis. Also, the fact that the tectum is thick, you can see a very thick tectum on the MRI as well as on the ultrasound, and also the fact that the junction between the pons and the midbrain is a trifle narrow. So this is JSRD or Joubert syndrome related disorder. Now let's look at this presentation. Here is a case who came with a red flag. This lady is 33-year-old. She comes with a history of Her first child, 11 years, Joubert syndrome, confirmed Joubert syndrome. And now you see that on your NT scan, you find what's happening here. The IT is increased. My heart sank. I said, what am I going to tell her? All this was even before we went molecular. These are old cases. On axial section, you will see again the prominent cystic looking intracranial translucency. And I said, you go away, come back to me after a couple of weeks. She presents at 19 weeks. At 19 weeks, you have a classical open fourth ventricle which is longer than wider. But what is hidden in this puzzle is the fact that you can easily recognize what shape. The molar tooth. The molar tooth is already there. You do a mid-sagittal section. Again, you see the C-shaped classical picture, a small midline cerebellum. I'm not going to call it the vermis, and which is, in addition to being small, it's also rotated. So this is how it can present either as a kissing hemisphere sign or as an open fourth ventricle sign. Here is another old case, 27 weeks, you have an open fourth ventricle, and when I go a little cephalad, you have kissing hemispheres, but this fetus also has polydactyly. So we did an MR prenatal at 27 weeks, and I was not convinced about a molar tooth sign there. Neither was my radiology colleague convinced. So we said, go back home, but we described, the neonatologist described everything about Joubert syndrome. And at 6 months of age, this lady calls up, says, I'm going to stop. You want me to stop? 5 minutes? 10? Yeah. 11 minutes. Okay. So this, okay, great. So this lady said, my child is not fixing. It's not seeing me. It's not seeing my finger when I move it. I said, go, and it's got abnormal movements. So she went to the ophthalmologist, and then I said, don't come back to me until you finish her MRI. And postnatal MRI at 6 months shows you what? A classical molar tooth sign. So this tells us that, yes, findings can evolve. It can evolve in pregnancy into the postnatal period. So your pattern recognition is kissing hemisphere sign or an open fourth ventricle sign and your classical C-shaped cerebellum that you have in the midline. Moving on to Romancephalosynapsis, the cerebellum is really tiny and small. So you measure it, it's lesser than third centile. Lesser than third centile, it's small. But most importantly, in Joubert syndrome, you have hemispheric identity or no hemispheric identity. It is there or not there. You can see hemispheres as hemispheres, but that ceases to occur in rhombencephalosynapsis. You do not have hemispheric identity because the hemispheres seamlessly are continuous across the midline, giving the cerebellum a globular look. And when this becomes globular, what is the fate of the space around the cerebellum? That's a cisterna magna. It becomes crescentic. It's no longer a lozenge shape, becomes crescentic. And if you wait till the late second trimester or third trimester, what will you see here? You have the foliae which are continuous. Now, also the fact that we need to know what is this structure called the vallicular. Vallicular is that prominence of the cerebellar hemispheres which go up and result in a notch there. That vallicular is absent typically in rhombencephalosynapsis. And if you look at the fourth ventricle can also be longer than wider. And this is the hemispheres and the grip. This is the globular cerebellar form in rhombencephalosynapsis. Here's again a rhombencephalosynapsis. That is the crescent over there. And in the midline, again, there is no vermis. It is a midline cerebellum, which is echogenic or hypoechogenic, most of it. Hypoechogenic, and the echogenicity is only limited to the surface because it's folia and not fissures. Here, of course, I saw this hyperechoic structure, unlikely to be the choroid plexus, could possibly be the nodulus. And this is the fourth ventricle, which is diamond shaped and which is longer than wider. Again, a rhombencephalosynapsis that you can see here, but in this particular case, in the midline, you have a thick tectum, you have a thin pons that you have here. The thick tectum is seen in the rendered image. The pons is thin. You have the foliae going across the cerebellar hemispheres, and at an inferior plane, you have a long fourth ventricle that you can see here. And in this particular case, from the volume, I do a section. I use VCI, OmniView, and I cut perpendicular to the midbrain. That's the tectum, that's the aqueduct of Sylvius, and this is the tegmentum. And what do you see here? You see a heart-shaped structure which represents the mesencephalon. So you have the tegmentum, which is separate, but instead of the two colliculi, inferior or superior, you have one peaking colliculus, and that's the classical heart shape that you get of the midbrain. I have inverted it and given you the heart shape over here, and this is mesencephalosynapsis. Here again is another case of the rhombencephalosynapsis, but here there is ventriculomegaly, a gross ventriculomegaly here in the frontal horns as well as the temporal horns, and there's absence of septum pellucidum or the cavum septum pellucidum. These are the temporal horns which are dilated. Note that the hippocampus is not only thinned, it is under-rotated for 25 weeks. And of course, you have other findings which are very, very important. At 25 weeks, I'm supposed to see what sulcus here. This is calcarine sulcus. For 25 weeks, are you happy? No, you're not happy with the calcarine sulcus at all. And in the coronal section, look at the lateral fissure. For 25 weeks, this is obtuse, still obtuse. So I feel there is a shallow lateral sulcus as well. You go mid-sagittal, and in the mid-sagittal view, you find that the or before the mid-sagittal view, I just want you to go back to the transthalamic view. You have those are two lateral ventricles. What do you expect here? What comes here in the transthalamic view? Third ventricle. Do you see the third ventricle? No. Instead, the thalami are fused, continuous with each other. You have a small fragment of the lumen there, and that is actually a large massa intermedia or interthalamic adhesion, which is very, very large. And on the mid-sagittal section, you find a large massa intermedia, residual third ventricle that you can see here, telling you that, yes, there is a diencephalosynapsis. Just like mesencephalosynapsis, this represents a diencephalosynapsis, telling us that these are corresponding to holoprosencephaly in the basal ganglia and in the mesencephalon and perhaps in the rhombencephalon as well. And in this case, it was a male fetus, and there's an adducted thumb. We suspected an L1 cam mutation, but we couldn't get the whole exome done for various reasons. Now, here is another case, 24 weeks. And this is interesting because in the coronal view, you have a bit of an echogenicity over here. There's no echogenicity here. Those are the cerebellar hemispheres. And when you do a mid-sagittal section, you find the vermis, which is, or the mid-cerebellum that is seen here. But if you look carefully, the upper half is hyperechoic or hypoechoic? Hyperechoic, and the lower half is hypoechoic. And therefore, this is a partial. This is a partial rhombencephalosynapsis, and this difference is also shown to us very clearly in the rendered volume images. A partial posterior RES anterior vermis is present, and of course, in addition to that, the corpus callosum was thinned out and hypoplastic as well. Here is a third ventricle dilated, lateral ventricles dilated, aqueduct not forthcoming at all. And this is again a mesencephalosynapsis. On one side, there is a microophthalmia here, and this is Karina's paper. And because of this paper, I could really understand how to distinguish between a rhombencephalosynapsis, which is complete, from a rhombencephalosynapsis, which is actually partial. Very, very beautiful. I want all of you all to read this wonderful article. So what is your pattern recognition? That's the globular cerebellum. And what have I tried to show here? Those straight lines. Folia, that's the crescentic cisterna magna. And this is, that's it. Cerebellar hyperplasia. I'll just straight away take you to an example. That is a 31-weeker, and a 31-weeker, you have a cerebellum which is 2.6, less than percentile. That's the MRI that you have here, compensatory increase in the size of the cisterna magna. And when you go up, you have a cisterna, you have a CSP and a CV, or a cavum vergae, but the cavum vergae is got biconvex. So I strongly suspected a cyst sitting out there, and you have cysts over here, periventricular cysts out here, and you can see that on the MRI as well. The cyst, a narrower CSP and a bulged out CV that you can see here. But remember, this is 31 weeks. There's no operculation there. There's no operculation here, and it's very, the PO sulcus is seen, but the cingulate is not seen. You know that there is a lissencephaly. You know periventricular pseudocyst, cerebellar hypoplasia, and of course, this is the MR of the coronal showing you the cyst there, and this is the biconvex nature of the CV that you can see here. But what was interesting is the limb findings, the upper limb findings. You will see that it's a fixed posturing that you see here, and at 31 weeks, this fetus was throwing fits. It's remaining quiet, and suddenly it goes into a clonic seizure. So there were seizures, upper limb contractures, delayed sulcation, CSP cyst, PVPC, CH. So we went molecular and we found a likely pathogenic variant, and the variant was indicative of mitochondrial DNA depletion syndrome 2, myopathic type. So the story starts with cerebellar hemisphere. You go on to the molecular diagnosis. We will take that off. Unilateral cerebellar hypoplasia is important. That's the tilted telephone receiver sign. Look for the circle of Willis, and if you find anomalies there, you're on the diagnosis of facies syndrome, which is a sporadic syndrome. We don't have time to discuss. Pontocerebellar, just to give you an idea of a visual idea, you have severe ventriculomegaly, a small size cerebellum. You go mid-sagittal, you find a brainstem, which is hardly a brainstem. This is called ventral hypoplasia of the pons, where the pontine belly is not as protuberant as it should be. That's pontine hypoplasia. With cerebellar hypoplasia, poor outcome, pontocerebellar hypoplasia. Another case, the ultrasound was not very forthcoming. We knew that there was a very small cerebellum there, a tough scan. The head was up in the fundus. We couldn't do much transvaginally. Went for a MRI. Just give me 2 minutes or 3 minutes. That's the small cerebellum. And on MRI, look at the streaky, very thin pons that you have. And of course, multiple contractures, as you can see here, and periventricular pseudocysts, as you can see here. So what is your pattern recognition? That's cerebellar hypoplasia, where the worm is also small, just like the rest of the cerebellum. This is the tilted telephone receiver sign in unilateral cerebellar hypoplasia and facies syndrome. And this, of course, is pontocerebellar, where in addition to the cerebellar worm is being small, in the midline, you have a pons which lacks its ventral belly, right? Tegmental cap dysplasia. Okay, now here is a complication we had. This was an Rh negative mother, isoimmunized fetus, and we did 4 transfusions. And I've told you the 20 weeks, 26 weeks, 29 and 32 weeks. But after the first transfusion, my heart sank because this is what I saw when she came back for her MCA. Both the hemispheres were hyperechoic. That means she has bled into the cerebellar hemispheres. And I told them, we'll have to look at the cerebellum in the future. At every visit, you come for a MCA assessment. And we measured the cerebellum just like we measured the MCA. And this perhaps is the most measured cerebellum in the world today, right? So, but we smile and we laugh now, but each time my heart was in my throat when this lady came, right? So, but the growth was good, no problem. And the boy is now 4 years old, doing very, very well, no problem. And this is how the ultrasound went at 24 weeks, resolution, and at 35 weeks, hardly anything. Looks good, although the cisterna magna looks a little, yeah. Now here is a cerebellum which looks uniformly hyperechoic, absolutely hyperechoic, not only the vermis, everything. And this is due to a vascular developmental anomaly, telangiectasia. You can see the gross specimen. You can see the histopathology showing you the telangiectasia going through and through. Yeah, and then Mobius sequence. This is interesting. Here is a 13-week. This is a conjoined twins. One twin bigger, doing well. The other twin smaller and had a host of problems. You can see a micrognathia, cystic hygroma. You can see a smallish head, a receding kind of a look compared to this forehead. But what's interesting is the fact that the IT was more. This is the occipital bone. This is the brain stem. And what has happened to the floor of the fourth ventricle? Calcified. And whenever the floor of the fourth ventricle is calcified, we need to think of Mobius sequence, which is a vascular disorder. But in this particular case, we had a lot of other findings as well. We didn't, this is hypertelorism that we found in this particular case. And the ventricles were full as well. I have no molecular answer. They refused any form of testing. Now, a rapid fire, a few I will take you through before I let you off. A 20-week case, you can see that there is an occipital encephalocele, and it's not only the occipital lobes, but the ventricles also have herniated, both of them. That is the sac wall. But when I come inferior, I lose the occipital horns, but what am I demonstrating below the occipital horns? The whole cerebellum is outside. And when you do a coronal, you find the occipital lobes outside, and you find the coronal of the cerebellar lobes outside. You do your rendered image, you find the occipital horns out, and this is the cerebellum, and this is classical Chiari-3 malformation that we have seen. So that is a thick tectum, and thick tectum should evoke a differential diagnosis of cobblestone malformation, tubulinopathy, Joubert syndrome, L1-CAM mutation, or cerebro-oculocutaneous syndrome. Here is a Z-shaped brainstem that you can see here, and you have all the other stigmata of cobblestone malformation. You can see the thick, shaggy pile surface that is happening over here. I will not take you to the other findings. No ocular problems, but when we did do molecular, we found a CRPPA mutation there. And that was homozygous, and it correlates with muscular dystroglycanopathy, which means it belongs to the Walker-Warburg syndrome or the muscle eye brain disease. So to conclude, determine correct gestational age, because without gestational age, you can't do any of your the measurement referencing. Basic examination, if there are any anomaly or changes or departures from normal, move on to multiplanar. And I would strongly exhort everybody to take to transvaginal scan. Be a little patient. There are times where we've made a patient wait until the head has come down. I'm not an obstetrician. I don't have guts to do external cephalic version. No, I can't. I can't do this. But you can call her on another day, wishing and hoping that the head comes down. Do your 3D, store volumes. You might ask for MRI, and of course, do a thorough TIFA. You might need to repeat ultrasound and MR examination and DD or differential diagnosis on the on the basis of pattern recognition. Always think molecular, always advise molecular. Tell your couples that this is not for this condition. You know, a Joubert is bad, poor prognosis. You know, RES is poor prognosis, but tell them that it's for your future pregnancies. That's important. You need to invest now so that you can get an early diagnosis in the next pregnancy. And of course, that will help us give the final diagnosis as well. Multidisciplinary, your geneticist, your developmental neurologist, and of course, the patient makes a choice. Thank you very, very much for a very patient listening. Thank you. Thank you.
Thank you so much, sir, for keeping us on the edge of our seat.
Last 5 minutes, Gustavo is going to address you what you should do when you are doing a CNS examination. So because now we have William Dobbins had another Zoom meeting, so he has disconnected from the Zoom, and it's you to advise everyone what you are going to do it. Let's do it tomorrow. Okay, we will do it that tomorrow. So we have again we are assembling here. So we are assembling again here maybe in 45 minutes again. We are going to start the evening program for the cultural evening program here in the same room, and we have dinner also here in the same room, or we'll go downstairs for the loan for the dinner. So please do come. GES organized some of the fantastic show, and we have also organized some of the pure Gujarati Garba. So you will enjoy, you will relish those Garba, see them. If you feel like doing it, join the group. Thank you very much. See you again in 45 minutes.